If a rural clinician come to you today and say, I want to open or keep my practice alive, where do I start financially? What would you tell them not to do first?
Not to do first.
Yes.
Do not spend a ton of money on your office.
Let's talk purely around rural health financing now. We are in a moment where there's increasing operational costs, and you've mentioned it, vendors and suppliers dictate the price of the market based on how they are also exchanging goods and services themselves, right? But we are also seeing decreasing funding tests and even fatigue around what gets funded and what gets cut. At least with this administration, literally 60% of health budgets and R&D budgets have been cut off. So how does this reality shape everyday clinical decision in healthcare delivery, especially within private practice?
I mean, I think you're seeing it, especially speaking in the rural health areas, right? You hear rural hospitals closing down, critical access hospitals are even shutting down. There's not, as you mentioned, not that many physicians that are in rural areas. There are some, Medicare and Medicaid. So Medicare insurance for the elderly, Medicaid insurance for people that don't make as much money. There are incentives built in for rural practices, rural communities to be seen, but that by itself is not enough. There is, if we go back to rural hospitals themselves, there's typically a low commercial insurances, which make up for the low payments from Medicaid. And there's lots of ER visits, and ER visits typically many times go uncompensated because they have to take care of everyone. So when it comes specifically to rural hospitals, it's very difficult for them to survive, which is why you need a robust, kind of outpatient clinic setting, and and I think private practice can play a big role. We can be way more efficient is one of the big things. We can be lean and efficient, and we can find ways to be creative to take care of patients. I mentioned the preventive care, right? So I don't think that we're doing a great job in the U.S. health system in general for preventive care. I spend a lot of time and I have a lot of passion about discussing that. And I think if we can, start that at a much younger, earlier age, and that will prevent many problems down the road. Heart disease is the #1 killer in the United States. The vast majority of that can be prevented. We just have to really figure out how and be able to get that care to the people that need it most.
Okay. So, but in this that you just discussed, what would you say would be the biggest financial pressure that people outside of the healthcare system are not currently seeing that healthcare providers are seeing, especially with this new financial constraint?
I think what I see the most just in my own practice is that the out-of-pocket costs keep going higher and higher, right? So it used to be that everything was a $20 to $50 copay when you came to see the doctor. Now it's, I routinely see patients paying more than a couple $100s to come in for a new patient visit. And especially if you have multiple doctors, that obviously becomes untenable really, really quickly. Many of these patients need further testing, and, so the costs definitely add up quickly. And so that's what I see from the front lines. I'm not, I'm not a Washington insider or anything like that, so I can't really speak to the greater infrastructure as much that's going on in terms of the budget and things like that. But just what I see from the front lines, that's the daily cost that's going up for patients.
I absolutely agree with you. I am one of those persons that is experiencing spending so much money, and sometimes I'm like, why do I have health insurance if I pay this much afterwards. So I definitely echo back what you have just said. But now let's pivot and talk about this business model, this health financing model that is called private practice. How did you design your model to remain financially viable while prioritizing patients' care?
So I like doing things that are wins all around, right? The patient has to buy, first and foremost, be winning. It has to make private practice achievable and even thrive. And if we're including other people in there, they have to thrive too. So one of the big things that's helped me just from a mental standpoint, but also operationally and financially standpoint, is being able to delegate, right? You delegate as much as you can so the doctor can focus on the tasks that really matter to him. And so I mentioned before, one of the big things we've done is go offshore.
Mm.
We hire really great people where this is careers, there's no turnover, and they get paid really well, and it saves us a bunch of costs. And I can hire people easily to be able to answer the phone calls, to be able to take care of those billing concerns, versus sometimes hiring the other person that might cost $25-$30 an hour. I've also developed different ancillary services. So one example would be this dietitian personal trainer thing we talked about. That's free for patients, so win for them. When right, preventive care, it's free for them, so it's not really a no-brainer. Again, it's a win for the practices, and I've developed a company called Pillar Health Solutions to try to offer that to other practices as well. And we've also, speaking of efficiency, I'm trying to use technology to be efficient as well. People we know that many times people don't come back in for care, right? They need to be seen for their 2-month follow-up or 3-month follow-up, and then they miss a couple of visits and then they get hospitalized and the costs then go way up, right? If we're missing them in the outpatient setting. But it's really hard sometimes to be able to call these patients, remember. So we're working on developing some AI, voice AI basically, that will take diagnoses codes from our EHR and when their last visit was, and just give them a call or a text and say, hey, it's time for your visit. Would you like to come in? So those sorts of things. So I'm trying to use whatever there is out there that's cost effective to make care more accessible, to make the clinic more efficient. And then, frankly speaking, when I solve the problem and I have a problem in my clinic and I am able to solve it, I know lots of other practices have the same problem. And so I'm passionate about helping them as well. So the software we're developed, it's under development now. And so we'll be offering that to other people soon as well.
Thank you. I want to piggyback off the pillar health system that you mentioned because I am part of those people who make strong arguments about preventive care, right? But what I have found out is, and this is me making assumption from threading all together the things that I've heard my guests say, plus the things that I myself have studied as a public health student, is that health insurance are not incentivized to cover preventive care. Not that we don't know that it keeps people more healthier and overall save costs, but I've had different schools of argument. One is if people are not getting sick, how do we get into the research part of health innovation? Because we need sick people to study that kind of sickness. And in doing that, there's also exchange of money, which means capitalist motivation in getting people sick and getting them treated, because that is where technology, innovation comes to play. And all of these things are also entrepreneurial driven. But you are here talking about prefacing preventive care as a sustainable health financing model. And you are doing this and you are also expanding it so that other private practitioners can come on board with you. Please take a little bit more of a time to explain this to me and the process of this pillar health system that you built.
Yeah, so yes, it's Pillar Health Solutions, but one of the good things, right? People have lots of strong opinions on the Affordable Care Act, but one of the good things that came out of it is they mandated preventive care. And it should be with no out of pocket. So, for example, everyone should get a colonoscopy at age 45 these days, and it shouldn't cost you anything out of pocket. So, these visits are considered preventive counseling. And so, because it is preventive, it is covered with no out of pocket costs. In terms of the insurance company's incentives, I don't know their insider information, but they have actuaries they're paying lots of money to that decide that look at their data and say, will this save me money over the long term? And potentially for some of these things they don't. For example, GLP-1s, if you know what those are all the newest phased, newest like weight loss medicines. And even though obesity is an FDA indication, most insurance companies will not cover that, presumably because they're expensive still, and then these patients will be on there for 2, 3, 4 decades. And so they don't think it'll save money. But fortunately, the preventive counseling stuff is free. And so patients get unlimited visits with these people completely for free with no out of pocket. And we've been doing it for 8 years now, and it's worked out great. Patients, weight comes off, their clothes fit better, and I get to do what's the most enjoyable thing of my practice is take off medicines. I love taking away medicine. I prescribe medicines every day, right? That's not necessarily enjoyable anymore. But if a patient comes in after their health is improved, I've had patients that started, just walking 500 steps a day, and after this, they really got into it. Now they're doing their 10,000, their strength training, their diets completely changed around. They're eating a whole food diet, where previously they're eating the SAD diet, the standard American diet, with ultra processed foods. And so obviously it's very beneficial to them, and it also is a revenue source for the practices as well. So again, it's a great win-win. There's really zero downside to it. And so we've expanded that, like I said, to other practices, and it's been going great, and everyone's been happy.
Okay, going great. Can you share a story of this going great where you've helped a particular patient with this innovative tool or model to get back into level of health that they would say, oh, they enjoy quality life?
Oh yeah, I can remember a husband-wife couple that started doing it together, and over a course of a year, maybe a year and a half, they lost a combined 150 pounds. We got them off the majority of their medications, right? They went from diabetes to not having diabetes, or cholesterol normalized. I think a lot of people just don't realize how important lifestyle changes are, how important to longevity, to you being a vibrant human being, to mental health, to all parts of life, if you can improve those two things. And one of the big things that we try to get them to just, make small changes, but be consistent. All right, that's the biggest thing. And set up your life in a way where it doesn't take willpower, right? It should not be hard to do these kind of stuff. So we also have, we call them mindset coaches, but just to try to help them with kind of adjusting their life and setting things up in a way where you're much more likely to be successful. It's not just about going over the diet plan and, hey, are you eating this or eating that? Or are you doing this particular exercise? It's also trying to work within their life circumstances. So we have patients that are seen as early as 5 a.m. We have a personal trainer that work at 5 a.m., people that will be seen as late as 8 p.m. They work on the weekends, sometimes. So whatever the patient needs, we try to take care of. But yeah, we've had some great success. But the number one driver is consistency. If the patient shows up to their appointments, they will be successful. If you come to 2 appointments and you decide, oh, it didn't work for me, well, you can't really accomplish any of this in 2 appointments, right?
Yeah. So the idea is be consistent. Consistency gets you to the goal. Thank you so much. Now, I wanted to ask you, how do we scale this model to other private practitioners that are in severe rural communities? Or do you think that this model alone is not enough? It needs other forms of model. But generally, what's your plan on how we can scale this to a broader practitioners who are in different places where this could be very beneficial to people within that environment?
So I think most people are problem aware, right? If you have your own practice, you know costs are going up, you know it's hard to staff. So you are problem aware, but you may not be solution aware, where there is an option of going offshore, or you may be nervous about going offshore. And so that's, if you become solution aware, that it's our job to make sure, right, you are feeling good about it, you understand all the ins and outs about it. So I think, platforms such as yours can get the word out. And so if this becomes a more viable model, you can have more physicians in the rural areas, or nurse practitioners or physician assistants, or whoever the provider is, that it is okay, right, that you can thrive in your own community. I grew up in a small town in Missouri. The reason I'm a doctor is because of the family doctor in my small town in western Missouri. That was about 2 hours south of Kansas City. And that he was a pediatrician, he was the surgeon, he did everything. That's, that doesn't exist, he says. But fortunately, he was there because we didn't have to drive, an hour away to get a doctor, and he was in private practice. There was one psychiatrist in the town. He was in private practice. This was the early 80s, where it was much more viable. But because I have that connection to that small town, I want, these communities, these physicians and practices to really thrive. So I just think we got to sometimes think outside the box, not how we've done things for the last 20 years. Because if we do things the same way we've done for the last 20 years, there won't be care there. And so we just have to think about some of these other ways that we can survive and thrive.
Yeah, I absolutely agree with you. Technology is moving us towards this direction, and we are upending even the last technology that we saw yesterday, And one thing that I like about what you've said is a lot of people make argument about the role and the use of AI. And I have this conversation a lot about AI as a tool. And I tell people it is here to stay. People who understand how to navigate the system are building in on already existing systems with these technologies in ways that is helping them, hands off on things that needs to be hands off to something else. If there was no COVID, Zoom wouldn't be a place where people would comfortably sit to have long form meetings, and they will still be high level, official formal meetings. But here we are. Now Zoom has diversified to a whole lot of things that we are using it for, including doing this podcast. So I like the fact that the way you imbibe and incorporate technology, not just the AI aspect of it. And I know from what you're saying, there's a whole lot of algorithms that you are looking into, that the data is telling you what direction to move on. But we need to bring a lot of people also to look at the efficiency of what technology can do to us. I am from Africa, and the conversation that's been going on, and I think they brought that to Davos the last couple of days, is that we know that African AI tool come from the global north. We have studied what this technology can do for us, especially within the healthcare system, knowing fully that the ratio of doctor to patient is still liminal, it's small. But now we are trying to look at how AI can close that gap and make it easy for non-urgent imminent care can be taken care of through this process that you've just explained. And I was just sitting there and laughing. I'm like, look at my African people using, health technology tools in ways that are helping us deliver care closer to the communities who would ordinarily not have it. So thank you so much for bringing up this part of the conversation. But before we continue, let us take a quick break.
If you're enjoying this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are on YouTube too. Your support means a lot to us. Please like, leave a comment, share, and most importantly, give us a review. It helps others discover this important conversation.
Welcome back. You are still listening to What About Rural Health with Chinasa. So, Dr. Shah, we have talked about your model. Now, we're going to open that up a little bit to talk about investment diversification and innovation. If we stop thinking only about government funding and now start thinking about investment more broadly, what aspect of rural health are we currently underinvesting in?
So from a structural standpoint, there's been tons of money put into these hospitals, right? So, and it's important to have hospitals, so you can take care of the sickest people. I think I read that in 2024, the government spent $5 trillion on healthcare.
Mm.
And a lot of it is hospitals. It's uncompensated ER visits drive a big amount of it. Why are there ER visits? Emergency room visits. The emergency room doctors are trained so that if you come in for chest pain, they're not thinking that's acid reflux. They're thinking, is it a heart attack? Is it a blood clot to your lungs? So you're going to get a bunch of blood work, chest x-ray, potentially CAT scan. It's going to cost a lot of money. But what is the option of people if, one, they can't get into their primary care doctor, if there's not urgent care, so there's not other places of care other than the ER.
Mm-hmm.
So again, I think really putting money into getting these clinics there, changing incentives so it makes sense for outpatient settings to be there in a rural community. We follow incentives.
Yeah.
Wherever the incentive, this is a capitalistic society, so we're going to follow incentives. And that's how legislation, that's how the tax code is built, right? The IRS wants people to invest in real estate, so they have all these tax deductions for real estate people. That's why Donald Trump pays almost no tax, right? Because of his real estate. So they need to have incentivizations to do the same thing for rural healthcare, right? So, and I think that starts with primary care, regular offices, clinics, preferentially private practice, but that's my bias there. But I think that's where the funding needs to go.
I agree with you. And sincerely, I was going to flip the same question I asked you and say, if we go beyond government reimbursement, where do you see the biggest opportunity for diversified investment in healthcare delivery? And I know you've mentioned primary physician, and I agree with you. I trust this is now me being a patient, right? I trust my primary physicians more than I would want to go to a specialist. At least let's begin the workup from my primary physician and let's that person advise me what next to do. Many people still do have that rudimentary sense of, healthcare access incorporated in their system, especially if you'd started off in smaller community where the primary care physician was caring, beside the fact that we think they know their job better, right? To where we are at now, where things are fragmented in different places. And it becomes a burden for one person to assess care because you go to a nose doctor for your nose, an eye doctor for your eyes, a ear doctor for your ear. It's a burden for many people who still do have 24 hours, just like every other person, to juggle work life and families and everything, including health. Now, I know you mentioned private practice, and I wanted to also ask you if you think that in diversified investment financing model for healthcare, that private practice is the viable model which you have established. Are there conditions that need to be made first for it to be sustainable?
That's a hard question. I mean, there's we're really bound by regulations and it is a free market model, compared to other healthcare systems, but it's not like going to McDonald's and right. There has to be lots of boundaries placed in terms of care. But again, I think the reimbursement models are difficult. If costs keep going up, reimbursement keeps going down, you're not going to have people in the most underserved areas potentially, you know? And so I'll give you like, when I was in my cardiology training, one of the attending doctors that was teaching me says, it doesn't make financial sense to see Medicaid, for example. We lose money on every Medicaid patient, you know? They did see Medicaid because it's an academic hospital, it's a university. But from a financial standpoint, it doesn't make sense. In Texas, the Medicaid reimbursement in regular, non-rural designated areas is very low. So most physicians will not take traditional Medicaid because it doesn't even cover the cost of business. And so if we're going to wanting to take care of these underserved populations, there's got to be something done about that part of things.
And this will be policy wise. Do you think there are specific policies that need to be changed? And is it going to be at the federal level or at the state level or the local level? Because I understand that all of these things have different weight to how they impact now the reimbursement system operational in different states.
Yeah, Medicaid is typically statewide. And so that would really have to be at the state level.
Okay.
Medicare is at the federal level, but those costs keep going up and up, right? We have more and more elderly people, the baby boomer generation, they're all retiring, they've all become 65. We want to give healthcare to everyone. We want to give the best technologies to everyone, but it does come at a certain cost. So in the end, the physician and the patient have to really be sure that this makes sense for them. Does it make sense to do a bunch of knee surgeries on a 99-year-old? I don't know. It depends on the 99-year-old. Are they still very active or are they wheelchair bound? So those nobody can make, tell us what to do. That's a clinical decision that the doctor and the patient have to make together. But in the U.S., that is something we'll potentially do. If you are back from India, where my parents are from, at 99, you're not getting any of that done. So some of it is cultural, some of it is structural. I think if it was a easy solution, it would have been done by now, but obviously it's very difficult.
I agree with you. We'll go for another quick break, and when we come back, we'll begin to wrap up. Do you want to help drive rural health forward? We are looking for passionate volunteers to support our work, from research to storytelling to outreach. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up. So, Dr. Shah, as we begin to wrap up, I wanted to ask you, if you could redesign just one thing, one part of the healthcare financing system to better support rural communities and independent providers, what would you change and why?
Oh, wow. One thing to change about the rural financing. That's a great question. It's hard to put your thumb on just one thing, right?
Yeah.
I think one of the hardest things is the U.S. insurance system. It's very difficult because you have 20 different insurance providers. You have 100 different plans between all of them. It is not easy to even become, say you want to be in the rural areas and you want to see everyone. The amount of time and effort it takes to get into these insurance plans, if you're in the traditional insurance model, and the amount of time and money that each practice spends to even getting paid, right? Like an example I was using, I used a McDonald's example before. You go to McDonald's, you spend $5, you get your burger, right? Here, it is way more complicated, right? We have to get if you have an HMO type insurance, you have to get a referral from as a specialist, get a referral from your primary care doctor. We have to call for prior authorizations. I don't know when you come in through the door how much you owe us. So I got to have one full-time person calling the insurance company to say what is their amount that they need to give us. So we we probably have at this point 5 or 6 full-time employees just trying to get us paid through insurance companies.
Hmm.
It shouldn't be that difficult,
Yeah.
right? It shouldn't be that difficult. And then that's just on the physician side. It's even, I think, just as complicated on the patient side, right? Is this covered? Is this not covered? Why does it cost this much? You said it was going to be covered. How come it isn't? How come the doctor charged me this much? I mean, it's very opaque. It's not a transparent system at all. And so if we could change that somehow with a snap of a finger, that's probably what I would do.
I definitely agree with you 100%. So that's true. I would also ask you, if a rural clinician come to you today and say, I want to open or keep my practice alive, where do I start financially? What would you tell them not to do first?
Not to do first.
Yes.
Do not spend a ton of money on your office. I have actually known physicians that started their own practice. They were super excited. They bought a big office. They spend tons of money and time to make it look at the prettiest thing ever. And, a pretty office doesn't dictate good care, right? You want to keep that overhead low. And typically, the two biggest contributors overhead is rent and staffing. So fortunately in rural areas, typically rent will be lower. So that should be much more affordable. And then we talked about staffing. You can go offshore, you can minimize your in-office staffing. But yeah, definitely don't spend a ton of money on real estate.
Do not spend a ton of money in real estate. That is
When you're starting.
just starting. Real
Long
estate.
term, yeah, go for it. But when you're starting, yeah, you don't want to put all that money, that fixed cost can kill you.
Yeah, I think that would be a very good advice to tell any startup person, because we often like to show a lot when we are starting off as a way to build momentum, but also gain respect and integrity. And then we invest so much money on the things that don't matter yet when we've not mastered the act of the business itself. So thank you so much for that. And I would add that, at least from this our conversation, one thing that I have taken from you is that you are building a private practice model that prioritizes patients' care in ways that leave them better off than the traditional system would ordinarily. And that's one thing that I appreciate in all that you have, that you have said. But most importantly, providers should be able, and I agree with you, when a healthcare provider doesn't have the autonomy and independence to actually, at some level, practice. I mean, there are certification processes, there are licensing processes, and there are practice concern that people also have when, it's just one person versus a system, providing mutual accountability. But all of those things can be built in into the way care is provided if patients' care is prioritized by the practitioner. So I like to have the autonomy to do what I've been in school for 35 years now doing, and not have someone over the phone dictate whether I should prescribe medicine or not, or whether I should take care of a patient or not. And all of these things all built into how patients receive quality of care. And here you are letting us know that private practitioners can do better if they use certain model that remove certain responsibility off their hands so that they can focus on the patients and deliver quality care to them. Before we wrap up, I want to ask you one last question, just one last question. If we are serious about improving rural access, what needs to change first? Is it financing? Is it policy? Is it leadership? Or is it, the sheer mindset of providers? And what role can clinicians, investors, or communities themselves play together to get us to this point?
Yeah, I think the mindset plays a role, that this is a viable place, a viable model to go out into the rural areas, to explore those areas. We bring care closer to where it's needed. We bring it closer to patients, but it also makes sense from a financial, from emotional, from mental, from a physical, from every perspective. It makes sense to go out there. And so if we explore these areas, we explore some of these tools that I've mentioned, I think that you go out there and do it. The mindset shift has come first.
I totally absolutely agree with you, because we need to shift our mindset from overly capitalism to be able to restructure the payment system in a way that sounds us better. So I agree. Thank you so much, Dr. Shah, for joining us and for sharing not just your expertise as a clinician, but your vision for making underserved healthcare accessible and sustainable. For our listeners, I hope this inspires you to think differently about rural healthcare funding and the role private practice play or can play in keeping care local and accessible. To everyone listening, thank you for joining us on today's episode of What About Rural Health? If today's episode moved you, challenged you, or make you think a little bit differently, please follow, subscribe, leave us a review on your favorite podcast platform. And as always, we will keep asking the question, what about rural health? Until next time, I'm still your host, Chinasa Imo. Bye for now.